Very good evening to everyone, and I thank all the panelists, Saurabh, Dr. Vipin, Amit, and Arjun, to agreeing to be part of this panel. And I would be mainly discussing the current and emerging practices on the management of neck and oral cavity carcinoma. So coming to the So as we all know that nodal metastasis is most common prognostic factor for oral cavity squamous cell carcinomas. And whenever the occult metastatic disease rates are more than 20%, we do elective neck dissection. But still, there are few factors or few issues which we need to discuss about these clinically node negative patients for oral cavity cancers. So the presence of node, it upstages the disease, we know, and there is reduction of overall survival by 50% as there is nodal metastasis, and it further decreases when there is extracapsular extension. We know that the patient will need adjuvant radiotherapy, and as the number of the node increases, their size increases, or extracapsular spread is there, the prognosis becomes worse. So I just thought we would, because it's a big topic, and we can discuss few of the important points, like what is the ideal imaging for neck nodes, especially for N0 neck. Then there is controversy regarding elective versus therapeutic neck dissection. Do any one of us do in-continuity neck dissection? Is there still a role for in-continuity neck dissection? Then do we need to do contralateral neck dissection for lateralized lesions? And the utility, and are we going to save 2B or not 2B? And then what is the status of sentinel node biopsy? So when we talk about the imaging for neck nodes, question to the panelist, do they decide the imaging based on the what factors they decide when they do imaging for oral cancers? Does it depend upon the N0 neck status? Will it be different? If it becomes N+, will it be different? So Saurabh, Dr. Vipin, Arjun, or anybody can take this.
So Poonam, if you see that whatever the available data, there is no imaging technique which is foolproof for neck node metastasis. Rather, all are to some extent same. If you accept one hyped article, that is the which shows that USG-guided FNAC is the best one, but we have found the lacunae of it because majority was debunked paper, where majority was N+ neck with and where FNAC was excellent. And we have parallelly our institute paper. We have shown in N0 neck the sensitivity of neck node FNAC, USG-guided FNAC is 14%. So when we go for imaging for oral cancer, always our decision of imaging on the basis of the primary tumor. So we never take the decision on the basis of the neck node evaluation, especially N0 no question. So this is always on the basis of primary tumor.
Correct. Dr. Vipin?
Yeah. Thank you, Dr. Poonam. And as Dr. Saurabh said, that the imaging has to be done in all the cases. We do in all our cases, and it is basically the imaging of the primary which dictates the imaging of the neck. So we usually do a contrast on a CT scan for the primary tumor and along with the neck. And if you think there's no separate imaging for N0 or N+ neck. So basically that image suffice, and if the neck is positive, we are more interested in the location of the lymph nodes, and their number, and the tumor, the nodal volume. That is what we are more interested in, and its contact relationship with the great vessels. So that is what I am interested in when I'm deciding for the imaging. So it is basically the attributes of the primary tumor which dictates the imaging, whether it is CT scan for a gingival cancer or an MRI for a tongue cancer.
So as the panel, please go ahead.
Just to add, ma'am, to what everyone said, I think if there are large, bulky nodes, multiple nodes on a lower neck level, and especially on bilateral sides, I think a PET scan should
Yeah,
also
and
be something that you would want to consider, because
Exactly.
these usually throw metastasis at a distant site as well. And this can give you a one-stop shop, investigation to complete the entire imaging. Additionally, in a post treatment, or if you have a response that you want to check, especially after neoadjuvant chemotherapy or radiotherapy that a patient has received, an MRI of the neck can also add a lot of value in differentiating between what is edema and what is actual disease and infiltration.
Yeah. So,
in
like the
post
panelists
treatment,
all, yeah,
rather again, Arjun, PET CT will be much more helpful because of uptake and all. But whatever you said, definitely for bulky nodal disease, lower node, contralateral node, we have to go for a PET CT.
correct. So, like all the panelists agreed on the point that usually the imaging for oral cavity is does not depend more or less on the neck nodes. It usually it depends upon the site or the stage of the disease in totality. I mean to say, it means it depends upon the site of the oral cavity lesion as well as the neck node, obviously. So, bone involvement, we know usually we go for a contrast enhanced CT scan. Soft tissue, you will go like you want to look for the tongue, oropharynx, floor of mouth, you would go for an MRI. And for multiple, like Arjun rightly said, multiple nodes, lower neck nodes, large nodes, and 3B nodes, ECS, you would like to do a PET CT. So that's the way we go ahead. I think there is lack of imaging with high accuracy, which Saurabh rightly pointed out, for any nodal detection in neck node. This bond and the meta-analysis, which was in 2007, though it showed that ultrasound-guided FNA is very accurate, it had its major flaw that majority of these FNACs were done on N-positive necks. Another paper by Saurabh with Pankaj sir, it showed that the sensitivity of ultrasound guided FNA was only 14.3% when it was early stage oral cancers like T1, T2 with N0 neck. So where are we? So if we see this article, which was published in European Archives of Otolaryngology in 2021, you see there are various studies. Many of them are prospective. Only one meta-analysis again by DeBont and other are retrospective. There is comparison between the three modalities. And if you see, there is a wide range of sensitivity and specificity, ranging from 59.2% to 100%. Having said that, again, like PET for N0 neck, PET again is not a great modality. It has very low sensitivity, around 58%, and moderate specificity of 87%. So just to bring to notice to all that we don't have a great imaging modality. They all have more or less the similar sensitivity, specificity, and accuracies. And you can select most of the time depending upon the other points like which we already described. So if you look into the evolution of neck dissection, we know that this neck dissection has evolved from some nodal metastasis removing by Cocker, then it went to a radical neck dissection, then by Cryles, popularized by Martin. Then it went to next step where there was conservation of structures like sternocleidomastoid, SAN, that is spinal accessory nerve, the internal jugular vein. So all those structures were preserved and it was called as FND or functional neck dissection or modified neck dissection. Then came another era where now we are talking about super selective neck dissection, or in fact, I would say now sentinel lymph node biopsies. So the era, this evolution of neck dissection has been to minimize the morbidity, but to have oncological safety at the same time. So I think I just put it for the sake of completion, because more or less the jury is out regarding the elective versus therapeutic neck dissection in N0 neck. But still, I would ask all the panelists, Amit, your take on that would you ever go for therapeutic neck dissection in N0 neck, or like your point?
After the decruiser trial came from the TMH, now we have to go for the selective neck dissection in the N0 neck. That is the principle which I am following now, and what has been taught during my research in the theory also. So generally, I go for elective neck dissection for any oral cavity lesion. Therapeutic dissection, generally, I don't prefer.
Sorry, your voice is cracking, Amit, a bit.
Am I audible now?
Yeah, it is a bit better. Yes.
Ma'am, after the DCRUISE trial came, this confusion was completely over that we had to go for the selective neck dissection or the elective neck dissection for the oral cavity cases after the randomized trial from the TMH came, in which the overall survival benefit was around 12% and the DFS benefit was around 24% was present. So elective neck dissection now is the treatment.
Dr.
So,
Poonam,
yes,
I just wish to add some. Oh, sorry.
Yeah, yes, please, Dr. Vipin, go ahead.
Yeah, what I was saying, just to complete what Amit was saying is, if I understand correctly, the selective neck dissection for N0 is we all understand, but the therapeutic neck dissection for an N0 neck, what I understand is that you are following the wait and watch policy.
Yes.
Am I correct? Or you are following a wait and watch policy, and all the N0 neck will not eventually convert into N1. N0 can directly go to N2. It can directly present as an N3 without having, and it'll occur in a very short period of time without giving an opportunity from N0 to N1 to N2 and N3. So the patient can directly present as an N2 if you, and don't leave an opportunity, don't miss an opportunity to do an elective selective neck dissection in a patient who requires it, because that is the best. And though you will be overdoing, but you will still be saving lives in these cases.
Exactly. So I think well said. The point here is that if you are doing a therapeutic neck dissection, most likely it is not going to be a selective neck dissection, which Dr. Vipin rightly pointed out. In majority of the case, it is going to be a larger node, it is going to be a bigger resection, and it is going to be a poor prognostic disease. So that's why this debate regarding the elective versus therapeutic neck dissection for N0 negative oral cancer goes in favor of elective neck dissection. I think we had earlier also other studies, also the meta-analysis by Fasunullah, but then there was a lot of criticism regarding that because there were studies which were done in different era. There were the kind of patients selected were not homogeneous. So I think the study by Dr. DCRUISE was the first RCT which actually put full stop on the point that yes, elective neck dissection is the way to go. Any comments, anyone?
I think this study has proved beyond doubt that we must do an elective selective neck dissection. Though we are going to overdo, we have to do more neck dissections to save one single life. I think the ratio is around 8 to 1. So you have to do overdo, but definitely this is a way forward.
Correct. I agree with you. So I think in like 30%, when we say occult metastasis, 70% we are going to do extra. But we don't know who are these going to be these 70% patient, 30% patient where there is going to be disease, and they may come with large disease, like you rightly said, and they will have poor prognosis. So for any N0 neck right now, the dictum is to do neck dissection because your locoregional control, even the overall survival is much more superior as compared to wait and watch or whatever you call it, therapeutic neck dissection. So coming to another, Saurabh, please go ahead.
Poonam, just I really want to ask the panelists, because in Dr. DCRUISE paper, there is only one hitch is there. If the thickness is 3 millimeter or less. So what we are, means in our practice, what we are doing for very small, means very superficial tumor, which are thickness are less than 3 millimeter or less. So what in our practice we are following, whether we are going for observation in this patient or we are going for neck dissection. So just I'm asking Arjun.
I think, sir, rightly said, I wanted to also bring this up. So it's not only the fact that the patient is N0. If the patient has a thin tumor with N0, then probably the debate still can, exist where you want to do probably a sentinel node, or some groups may say, okay, you don't even need that because the risk of metastasis is less than 3%. But in those cases, that's where the debate is. Anything which is a thickish tumor greater than 4 or 5 millimeters or 3 millimeters, the cutoff, I mean, each clinician can have their own. Even though it is N0, those are the necks that should be treated with a selective neck dissection.
So you are in favor of even in small tumor, thickness tumor, with the present data available, with a 2 millimeter thickness or 1 millimeter thickness tumor, what will be your plan to go ahead with neck dissection? Even I can, Poonam, what you
I
are
think I
following?
would, yeah, I would offer
yeah,
the
go ahead.
patient, I would offer the patient an alternative such as sentinel node biopsy, definitely in these cases, not just jump to a selective neck dissection. But again, err on the side of caution. Even sentinel node biopsy, if the infrastructure, and I'm sure we'll come to that in the subsequent slides, but even that is not a complete science if you don't have the exact protocols which other people have followed till now. And even if you have that, the protocols are so varied that, to be honest, you don't know which one to follow.
So Saurabh and Arjun rightly said. So I had put this point regarding the depth of invasion. Like you both rightly said that from 3 mm to 4 mm, if you see Dr. DeCruz's paper, it increases the lymph node positivity rate from 5% to some 16-17%. So having said that, Saurabh, in my routine practice yet, I don't do it based on the depth of invasion
I
of
agree.
the primary tumor. Why I don't do it, I will tell you the reason. Because I don't have a pre-operative imaging, even on MRI, I am not very sure. I know there are papers which correlate the depth of invasion of MRI with the depth of invasion on final HPR, but still we don't do it very regularly. And for me, usually to say that a tumor is thin, superficial would be more of a subjective thing. I need more objectivity to it. So if I have something pre-operatively, where I'm very confident, okay, this is a 2 millimeter lesion, I would go ahead about it, but still I have not thought about it, to be very frank. That's my practice. Dr. Vipin,
And moreover,
yeah, sir.
and moreover, it was just a subgroup analysis of 70 odd patients, 70, 75, I think 78 odd patients. And if you see that consecutive same study, where though they have not specifically told about the thickness, but in their study, even small T1 tumor, there was survival benefit with elective neck dissection. So with the uh, available
Yes.
data, I really
Yeah.
think 1
Sense
millimeter,
study.
even all oral cancer neck should be addressed. This is in my practice, but others, I can
Yes, I
tell
agree,
for Dr.
Saurabh. So
Vipin
this
or
Hutchison et al. study, SAM trial,
exactly.
they had shown that even with the early tumors, small tumors, there was survival benefit with EM.
Benefit.
Correct.
Yes.
So Dr. Vipin, do you follow that like we do, or Amit, because like me, Saurabh and Arjun has put their point of views. So what are your point of view regarding the depth of invasion? Do you follow it or will you follow it?
Definitely, ma'am. We do neck dissection in all the N0 oral cavity cancers, except for a very small tumors. But what is a very small tumor? I don't know. I don't know what is a very small tumor. But
Exactly.
any significant tumor, I would go for a neck dissection. Secondly, it also depends on the site of the which subsite is there. If it is floor of mouth, tongue, then I'll have even lesser threshold for going for a neck dissection rather than hard palate or a buccal cancers.
Correct. Amit, your views?
I'm similar to the sir, that I used to follow the same principle. If it's like the site is involved, is tongue or the floor of mouth, definitely I'm going to address the neck, because there is a high chance of propensity of lymph node metastasis in these areas. Moreover, regarding the depth of invasion, only by clinical examination, if I'm finding it induration over there, definitely I will proceed for neck dissection. But regarding the very superficial tumor, it's very difficult and catchy statement that I will observe, but can be observed if patient don't want to undergo for neck dissection. I will ask the patient for the closely follow. That's all I can offer. But
Correct.
given a choice, I would definitely go for a neck dissection, elective neck dissection, N0 in case of oral cavity.
Correct. So I think depth of invasion is an important factor. But having said that, for students, basically, elective neck dissection right now for N0 neck is the way to go. We'll come to the alternatives which the panelists suggested, but we'll come subsequently. So coming to this more of a theoretical topic, I felt it is discontinuous versus in continuity neck dissection. So any one of you do in continuity neck dissection now? Dr. Vipin, Saurabh, Arjun, Amit, anybody can give their point of view. In continuity neck dissection, who among you all do it?
So, ma'am, if we are doing a compartment resection, then I think level 1B and 1A probably can be taken in continuity with the primary. But at least in my practice, I don't do the entire 2, 3, 4 along with the rest of the primary nodal and nodal basins. But I think level 1B is an easy target to take with the primary without much logistic effort.
So tongue lesions you're talking about, the larger tongue lesions
Yes, ma'am.
where you
Tongue
can.
and buccal mucosa both. In case you fear any tumor nodal tract, spread, or you want to take out a large tongue lesion along, that has an N plus disease, or you want to do a small tongue with an N plus disease. In either situation of your practice that you would want to do a compartment resection for the buccal mucosa as well as the tongue. I think level 1B and 1A is an easy in continuity resection to achieve.
I agree. And if we are going for compartmental neck dissection for tongue, most of the time we take it. Buccal mucosa, again, if we are going for a mandibulectomy, so forget about anything. It gives it saves your time. If you are not doing, just take the vessels and you in continuity you remove. But I never do it the entire neck in continuity with the primary. Uh, those cases, I take one B mainly, not every time 1A. If it is a lateralized disease, it's only 1B, but not other level I take in continuity.
So
I take it separately.
Dr. Vipin, yeah, Amit, yes.
Ma'am, what I found, once or twice I had a discussion with my pathologist. Whenever the tumor was involving the lower GBS sulcus and I take out the 1B separately, then they used to say the lower GBS margin was close enough. It doesn't give me a clearance in that area. So taking it together is the best option, so that you can get a full depth in there, your margins are clear. Otherwise, I don't know. I had a discussion with once or twice with my pathologist. They say, no, your 1B is, that lower GB sulcus area, when you go for a segmental resection and 1B is not included along with the primary, then they say the margins are not clear. I had that difficulty.
Dr. Vipin, your take on this?
I think it's very tedious to perform the primary in continuity with the neck dissection, but as per Amit's query that you take level 1 along with the, say, a segmental resection. So what I wish to say is that the pathologists are interested only in the mucosal margins. They will report only the mucosal margins. They will report on the neck separately. They'll report on them as separate lymph node positive or not. But I don't do it. I don't do it anymore. But when I was training, I was told this is the way to go, but I no longer do it anymore.
So even I agree with you, Dr. Vipin. So in my routine practice also, I don't do it in each and every case. But many a times, like Arjun pointed out, when we are doing a compartmental resection, mainly for tongue lesions or floor of mouth lesions, where we feel the base might come close at some point in the floor, which is actually difficult to describe, there we sometimes do it along with level 1B. Having said that, it's not that we do it for each and every case, because our compartmental resection usually ends at the level of 1B, at the level of the hyoid bone. So I think there is some data. This is one of the meta-analysis which showed that in continuity neck dissection actually lowers the locoregional recurrence rate. But again, as we know that all studies have their inherent limitations, and this also has its own limitations. So what is this in continuity neck dissection? Just for the students, this is the concept of removal of lingual or sublingual lymph nodes, which are usually located within the facial or intermuscular spaces of the floor of mouth above the mylohyoid muscle. So when you are doing a compartmental resection, you are going to remove it. Compartmental means like whole compartment. Suppose tongue, you are going till the hyoid. But when you are just doing a wide excision, like for early tongue cancers like T1, T2, most of the time these will be left behind. But do we need to remove them always? No. Actually, their frequency is very low. Second, If you are going to do a compartmental resection, you want to remove these nodes, and each and every case, it is going to be a morbid procedure. So you have to always see the risk versus benefit ratio, and that doesn't fit for your early cancers. For again, the study which the meta-analysis which shows that it has an edge over the discontinuous neck dissection. Again, there are heterogeneous group of studies. Then it depends upon so many other factors: extent of neck dissection, retrospective studies, data not available properly. Then we don't know the proper adjuvant therapy what was given, because it do make a difference. So I think that, again, that food for thought, probably they can be considered for T3 and T4 tumors, but for early lesions, I think we should continue with wide excision and a separate neck dissection. So coming to the, please go ahead.
Dr. Poonam, if
Yeah.
you go through the paper by Cesar Piazza, in which he describes that there is a unique problem with the compartmental tongue resection. Why he advises a compartmental tongue resection is because a TN tract is very short. The physical distance between T in tongue and is very less, and the nodal basin is very less. So that is why he recommended the continuity as a compartmental neck dissection. And you will always have to put a flap in these cases. The free flap would be required in all the cases when you're doing a in continuity resection. So that is another disadvantage. So for definitely the point is that for early cancers, you can go for a separate resection, and for when you're planning a compartmental resection, you have to do in continuity resection.
Correct. So coming to the non-surgical management of neck, I just thought we'll touch upon it. So do you ever consider, any one of you, non-surgical management of neck in oral cavity cancers? So like, it's difficult to say only for neck, because it will be mostly together for the oral cavity as well as neck.
I think
we never recommend non-surgical, but there are many patients who already have made up their mind and come to us that we don't want a non-surgical management. So they already come to us many times with a paper in their hand that we want this chemotherapy because their neighbor or their friend took that chemotherapy. So we do get, so it's a patient who decides, they don't give an opportunity to decide for a non-surgical treatment.
I think, ma'am, one of the indications for contralateral neck being treated by by radiotherapy would be in a tongue cancer. Usually you want to radiate both sides as an adjuvant therapy. One side you're treated and you give it the adjuvant dose, but the other side you give a radical dose in certain cases. So that would be one of the rare instances as far as a protocol is concerned for management of neck non-surgically.
Correct. So most of the cases we won't be considering for non-surgical management of oral cavity lesions. We all are aware. And I just thought, just for the sake of completion, this study, which was a randomized study by Gopal Krishnan Iyer, this had clearly shown that patients who are treated with surgery, Vishal, somebody is making changes in the slide. Please don't do it. So randomized study between surgery and with concurrent chemoradiotherapy. It usually has shown that there is definitely difference in the disease-specific survival for cancers of oral cavity or maxillary sinus. We can see it is 70% versus 0%. So if we can operate, it is operable, patient agreeing, surgery is the way to go. There's no question about it. Can we please correct it? Somebody has done it. Can we erase it? So coming to the next slide, just that regarding the pattern of cervical lymph node metastasis from the squamous cell carcinoma of the aerodigestive tract. We all are aware of this seminal paper by Dr. Jatin Shah, and we know how the pattern of lymph node metastasis happens in the neck for oral cavity, oropharynx, and most of the other sites. And so here the question is, now we know that how this spread happens. So how do we, what should be the extent of neck dissection? So I have put it together, few of the questions which are routinely we discuss or is debated in various conferences. Should any one of you spare the 2B, or you do it as a part of your routine surgery? First we'll come to the 2B. So Saurabh, do you spare 2B for N0 necks now, or you still go ahead and do 2B? when you are doing a selective neck dissection?
Look, there was the Gauri Madam's paper, 583 patients, where she has shown that if there is level 2A positive in frozen section, then only there is need for doing 2B and 5, according to that paper. But in my routine practice for N0 neck, actually, I don't send for frozen section. This is my practice that I always address the 2B and 4. So normally for N0 patients, it's always 1 to 4. I don't address the level 5. But again, if anyone is doing level 2 and frozen, then it is equally good. But the main problem with, there are two problems with level 2B addressing and level 4. One is for level 2B, the handling of spinal accessory now. So I generally don't give traction to the spinal accessory and do a meticulous dissection with quad bipolar. And so the outcome becomes much better if you don't give traction. And secondly, for level 4, the only problem is the in mainly on left side the chyle. And if you were meticulous, if you were taking tie, and also my teacher Pankaj sir used to say that having an injury in chyle duct is not a complication, but if you are not means ligating it the chyle duct, then it is a problem. So if any time it happens, then we just take it. So
So
I
Amit,
routinely do 1 and
yes.
4. 2B
Oh,
and
you
4.
do 1 to 4, including 2B, Saurabh.
Yes.
Yes. And Amit, what do? You spare 2B or you remove it? You save it? You remove it?
And for N0, I try to spare the 2B, but for N plus disease, I'll go for 2B.
Sorry.
Ma'am, for N0, generally I spare the 2B, ma'am.
Okay. Okay. And do you send it for frozen?
Ma'am, frozen, no, sir. No, ma'am.
Okay. Okay. Your clinical impression.
Yes.
So I think this is because of the shortage of time. I will just try to complete these questions. How much time we are left with? So I think we have to see that, okay, so this Gauri Madam's paper which Saurabh quoted, that level 1 to 3 was involved in most of the cases, 91% cases, and level 2B was actually involved only in 3.8% cases. And there was no skip metastasis to level 4 and 5. And similar data from other papers also. So I think there is some data to tell us that, okay, if you're not doing 2B, the shoulder function is going to be better. And but again, it is a matter of practice that we are saving the 2B or not. I think it depends center to center. Just contralateral neck dissection. Arjun, do you do contralateral neck dissection based on few factors for lateralized lesions, like this study shows from our own institute by Manish?
Yeah. So if there is a large skin involvement that was found in this case, you'll get a higher chance of contralateral neck dissection. But in my practice, I don't generally follow this kind of thing. What happens is that if there is any form of disease, whether the primary or the nodal metastasis towards the midline, then I go in and I at least do a 1 to 3 on the contralateral side if it is N0. If it is frankly N plus, I will do the contralateral neck. And if it is a recurrent disease, then in our practice, we also treat the contralateral neck with a neck dissection. So these would be the three indications that I would.
So I agree. So usually a lesion which is reaching midline, crossing midline would be the main indication to a opposite neck. Ipsilateral lesion, even with just with one study, I may not be agreeing all the time. And many a times, if their nodes also ipsilateral, continental node are negative, many a times radiation can take care of that because they will be radiating the neck. So so I think another point is like this study again by Monali from our own institute has shown that if there are 2 or more lymph nodes in the neck, then we should address the contralateral neck. So skip metastasis to level 4. Dr. Vipin, do you do for tongue lesions, you do level 4 also or for buccal mucosa also for N0, or you do level 1 to 3? What is your practice?
For buccal mucosa, ma'am, we do supraomohyoid neck dissection for an N0. But for mid-lateral border, the middle part of the lateral border, if it is involved, then I also include the level 4 into the next. So 1 to 4 for mid-lateral border of the tongue.
Correct. Saurabh, your practice? You do level 1 to 4 always, you said.
Yes, do level 1 to 4 always. And for contralateral, the means extensive skin involvement we do, but not for all positive neck. If it is reaching the midline or crossing the midline, then not.
Amit,
And one
your-
involvement.
Yeah.
I'm 1 to 3. I
1
don't go
to
for
3.
a tongue. Yes, ma'am. For tongue, I don't go. If it's N0, I don't go for level 4.
You won't go for 4. Okay. Arjun, I think you do 4, like we all do.
Yes, ma'am. But much after Bayer's 15.8, we recently published our work around 2 years ago on skip metastasis in an N0 situation. Bayer's 15.8 had a lot of controversial statements, including a definition of what he considered as skip metastasis. So in our paper also, we found just 1 out of 800 patients having the true definition of skip metastasis to level 4. So in an N0, where you have a nodal metastasis only at an upper cervical level as 1A and 1B, it is highly unlikely that it will skip 3 and jump to 4. And an isolated level 4 metastasis without having any metastasis in the prior levels is absolutely zero in all studies. So that is the conclusion from our study from our institute.
Yes, so I agree with you because most of the data, is correct. You're right. And I think this bias paper made us actually very paranoid, and it showed that 16% skip metastasis. And when careful examination was done, it was around 5% only. And there are other papers also. I think this is this meta-analysis, which showed that the level 4 metastasis rates are very less. There's like 13 studies. I know time is less. So I think 2B or not 2B, it is individual decision. But ideally, you should have a frozen section to decide if you're going to spare the 2B. That's my point of view. And usually, many a times, this 2B will be just a continuation of 2A. And I'm not sure where to stop and to call it 2B and to leave that node behind. That could be a bit of challenge sometimes. Isolated contralateral neck dissection in lateralized lesion is rare. And usually for level 4 isolated metastasis is rare, but again, it is individual practice. Even a level 1 to 3 neck dissection, if it is absolutely N0, which Amit said, can be considered for early tongue cancers. So just I will just take 2 minutes just to touch upon that now coming towards the sentinel lymph node biopsy, because sentinel lymph node biopsy is evolving field, and we should also be aware about it. We know conventional transverse neck incision itself has certain problems, and we do robotic neck dissection, retroauricular, but all have the similar complication, more or less, neck scar. Then if you want something which is somewhere in between your elective neck dissection and observation without the complications of elective neck dissection, I think the SNLB is the way to go. And we know what is SNLB. I will just complete because we are like ahead of time. And the sentinel lymph node biopsy is mainly for the lesions which are early T1, T2, and you can excise them per-oral, intraoral. But it usually needs a multidisciplinary team. It needs a lot of money, cost, and infrastructure. And there are certain advantages. But having said that, I think this is a paper which Saurabh had published long back in 2013, and it showed that it is a very good modality to detect the occult metastasis. It was even before the other papers by the randomized studies. And this is the SENT trial we all know of. This set the sentinel lymph node biopsy as an important tool to manage the N0 neck. Then the paper by Garrel, we all are aware, and Hasegawa. So why, but still the sentinel lymph node biopsy in most of the centers is given as a part of as a part of trial. Why we are not doing it routinely is because it is time consuming, it has a learning curve, and most of all, it needs the standardization of the surgical, nuclear medicine, and pathological techniques. There are so many pathological techniques which Arjun touched upon, and we need to have at least lot of money. It needs lot of infrastructure and resources. So having said that, this is the way to go ahead. But there are right now a lot of challenges and limitations. We are also in our institute, we are working to streamline this process. So to conclude, there's lack of proper imaging modality which can detect neck nodes properly in N0 neck, and continuous neck dissection I think can be done for advanced lesions. Isolated contralateral neck dissection in lateralized region is rare. Level 4 isolated metastasis is rare, and sentinel lymph node biopsy is oncologically safe and is superior to our elective neck dissection with functional outcomes. With this, I conclude, and I thank all the panelists for their great inputs in making it a good panel. Thank you so much. Hand it over to you.
Thank you.